Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon. I'm a physician scientist at the University of Colorado, and today we're talking about leptomeningeal disease, and I am joined by Samantha Murrell and Laura Alder. Maybe you both can go ahead and introduce yourself, and we'll kick it off with Samantha.
Hey everyone, Samantha Murrell. I have stage 4 lung cancer with a HER2 mutation, and I am happy to be here on a podcast with Kyle and Laura.
Great. I am Laura Alder. I'm one of the thoracic medical oncologists at Duke University in Durham, North Carolina. I'm also involved in the leadership of the Duke Cancer for Brain and Spine Metastases. And thank you so much for having me on your program, Kyle, and look forward to talking with you and Samantha today.
No, thanks so much for being here. I feel like you've been doing a hopping of different podcasts and other social engagements, so it's great to have you on here. Thanks for taking the time.
Yeah, very happy to.
Particularly around this challenging topic, this is leptomeningeal disease. I think a lot of individuals who are probably listening to this may not have heard about this entity, this diagnosis yet, and those who have, I think there's a lot of maybe nervous, anxious sentiment around it. So I'm eager to get into what it is and some of the realities behind it. So maybe just starting off, Laura, can you describe what leptomeningeal disease is?
Yeah, thanks, Kyle. And so, the leptomeningeal disease, that the leptomeninges are in the brain. And so you have these layers of tissue that are surrounding the brain and the spinal cord and into the cerebral spinal fluid. And that kind of cushions the brain and the spinal cord. And so sometimes the cancer cells, either through the bloodstream, through the lymphatic system, through direct connection, can spread into these delicate spaces surrounding the brain and the spinal cord. And when that happens, that is leptomeningeal disease, otherwise known as also LMD. Sometimes it's referred to as.
And how does this happen? What's going on to make cancer go there rather than other places maybe it more commonly goes?
Yeah, so good question. We know that a lot of cancers can have a tendency to spread to the brain, and there's a lot of different ways it can do that. Usually the brain, the spine, the meninges that we just talked about, they're protected by the blood-brain barrier. However, cancer has a really nasty way of figuring out how to invade things, how to get by things. And as I mentioned, briefly, sometimes this occurs through the bloodstream, and via the bloodstream, they can kind of break down some of that protective element of the blood-brain barrier. And we're still learning a lot more about how cancer cells do that, what makes some cancer cells more prone to be able to spread to the brain than others. And as we learn more about the tumor biology, how it can invade either through the bloodstream, through the lymphatic system, which is another kind of highway throughout the body of transportation. We're trying to learn more how we can prevent it, how we can make sure that the treatments we give can really get to the areas we want them to get to. Including the brain, the spine, and the cerebral spinal fluid, all of these delicate layers that offer such good protection to your body and to these delicate organs. But via that same protection can sometimes be challenging to make sure that our drugs get into that space and are as effective as we want them to be.
Sure. Yeah, thanks for explaining that. And I think this is confusing and complicated topic because we're talking about leptomeningeal disease as an entity that's in the central nervous system and inside the skull, inside the spine, but it's not necessarily in the brain. If you were to take the brain out, it's not in the center there. It's surrounding it.
Yes.
So it's all central nervous system disease, but those are two different entities. And for me, at least when I was first learning about this stuff, it was kind of hard to wrap my mind around it. No pun intended there, but because it's tricky. They're both in the central nervous system, but they're different. Things that are in the brain in the parenchymal area that we call it, or surrounding it.
Agreed. And I think, a lot of times we don't think about the layers and all these membranes and, the fluid in between membranes. And, the body is such an amazing and delicate, piece. And so there's so many different elements. And but I'm glad that we can talk about it and hopefully provide some education, because while thankfully relatively rare overall, we know it can happen anywhere up to 8% of certain cancers, breast cancer, lung cancer being two of the more common ones, but other cancers certainly also have a risk. And one of the things I always highlight is that we're doing better, but, we need more awareness. So both, patients know what to look out for, and we'll talk about that a little bit later, but also so, pharmaceutical companies, industry, they know that this is a space that deserves and needs more attention, needs more research, needs better drugs, better strategies to make sure that we continue to move the space forward and to make sure we continue to improve the outcomes for patients who do have involvement of the leptomeninges, of these meninges and the membranes of the brain and spinal cord.
Yeah, I mean, couldn't agree more. And I think the need there certainly has permeated through the patient communities too. Samantha, we haven't gotten into the details of what leptomeningeal disease looks like, prognosis, things like that yet. But I want to know, from your perspective, what is the patients, as a community, their perspective of LMD or leptomeningeal disease?
I think there's, first of all, quite a few misconceptions. I think a lot of people think that if they have never had brain metastasis, that they're not going to get LMD yet. I think a lot of people see LMD as a progression of brain metastasis. And what I'm learning is that's very much not the case in most cases. And so that's a big misconception. I think there's people out there that don't know that I can never say the word, leptomeningeal disease is LMD. I think a lot of people see LMD and they think it's something, and then they see leptomeningeal written somewhere and think it's something totally different. So I think there's a disconnect there. And I also will say, I think a lot of people just don't even know that it exists and it's even a thing to worry about, which, while I don't want to scaremonger and make people afraid, I think it's a very important thing to be aware of. And honestly, for me personally, LMD is the scariest of them all. I think it's just because, and I know Dr. Adler, you can speak to this, but there's still a lot of unknowns in this space in terms of what actions are available, what your prognosis looks like once you're diagnosed with this. It's very scary at this time. So I think just a lot of unknowns, a lot of misconceptions. And so I'm hoping that this podcast, I have 5 billion questions in my head zooming around right now, but I hope that this can bring some really much needed awareness to the community that might not be well informed, because I think it's important to have in your head lined up that if you get diagnosed with this, what are you going to do? I think that's important.
Yeah.
And Samantha, maybe building on that, from what you've heard in the patient communities or you've seen through patient advocacy groups, what are the signs or symptoms of LMD that people are aware of, you think?
The very few people that are, I think, aware of this or have read into it, I think dizziness, and tell me, Dr. Adler, if I'm way off base here, but dizziness, headaches, pressure, nausea, which I know a lot of those can also be tied to brain metastasis. So it's kind of hard to distinguish between the difference. And I do know that the spinal tap really is the answer to finding out if you have it or not. Although I do know some people that had a negative spinal tap and it did still end up being LMD. So there seems to be some uncertainty there, even when you think that that's the best approach. Yeah.
And Laura, before we dive into how challenging that diagnosis can be to make, which we've both been in that position trying to make that diagnosis, what are the signs and symptoms that particularly worry you and at least trigger the beginning of the workup or diving into the history about could this be leptomeningeal disease?
Yeah, so Samantha did a great job with some of the common ones, right? So headaches, nausea, vomiting, any type of like thinking differently, like confusion, any type of walking difficulties, like feeling off balance, feeling dizzy more often, weakness or numbness, and especially in like the toes and the legs, having new back pain or especially neck pain. And then this is an odd one a bit, but any bowel or bladder issues. So any having more like accidents, not being able to control going to the bathroom, because some of the nerves that run through the spinal cord that really help the body kind of regulate these processes, if they're affected by the cancer kind of pressing up against them, it can affect how well that what they innervate, how that works. And so, I always encourage my patients because Kyle and I and Samantha, you have this experience, with lung cancer, especially, brain mets are, no pun intended, always on our brain too. It's always on our mind, so usually we do surveillance. It's something that I always tell patients, if you notice anything differently, your body best. We want to know. There's nothing too simple. There's nothing that's not important enough. We want to know so we can help advise, because as you said, Samantha, a lot of these symptoms, all of us have a headache sometimes. Depending what treatments you're on, a lot of the treatments cause nausea, vomiting. Some of them can even cause dizziness and confusion. Some of the oral targeted therapies we have. But, I always want to talk about it with them and have a conversation so we can make sure that we can get to the bottom of it and make sure we can find out what's going on.
Yeah, and I'll even, add, I've had patients where as the nerves leave the central nervous system and spread out to wherever they're going to go, you can get cancer surrounding those nerves in and around the brain area up here and then down the spinal column. So you may see individuals who have a lid drop, like their eyelid won't work, their eye will deviate now, because the nerves that are going to innervate the face intermittently may be compromised by cancer surrounding them. And that can be true, up and down the spinal cord too. So sometimes you get these odd symptoms that almost look one might think it looks kind of like a stroke or something like that. And the premise is probably similar in that the nerves that innervate that area can be compromised. And it's an uncommon or unusual thing to see and think, could that be cancer? Because I think in my mind, until I really knew about this physiology, like I didn't think that they would be related, like your nerves and a cancer progression event. So it's tough. I think it makes the diagnosis of this really hard. And I've certainly been in situations where the diagnosis took a while because some of these things aren't always clear. They can come and go. So this is just a tough disease.
And I wanted to clarify something. So I'm very over the top in my scans, like way over the top. I get brain MRIs every 3 months, just because I've never had brain metastasis. I'm very nervous about it, want to keep on top of it. And it seems to be that in some cases you can spot leptomeningeal disease in the brain MRI, but then sometimes it can only be in the spine. So then you can't see it. So I'd love to hear more about, I guess, like diagnosis, what that looks like, and the different options that are out there. And and maybe people to not fully be reassured if their brain MRI is clear?
That's a really important point, Samantha, because I think, as Hal and I both alluded to, some of the symptoms, the leptomeningeal disease, those membranes expand along the whole CNS, including the spine, as you say. So sometimes it's not in the brain membranes, but it's in the spinal membranes. And so some of these spinal symptoms, like we talked about, MRI is needed if there's any suspicion of both the brain and the spine. And an MRI with contrast, gadolinium is a specific type of MRI, but make sure with and without contrast is really needed to make sure we image the whole central nervous system. And that's usually the gold standard, paired with, a lot of times, as you mentioned, that lumbar puncture. So we can really analyze that CSF, that fluid that's kind of lining and cushioning the whole CNS system too, and CNS central nervous system. But as both of you mentioned, that can be really challenging, because that first lumbar puncture, where we get that sample of CSF, it's about 50-50 if you're going to get the diagnosis, even if you have it. And so oftentimes we need multiple rounds of lumbar punctures, and it's painful. It's usually it's not, we have incredible people who are performing it, but it's not the most comfortable thing, to say the least. One of the exciting things, however, is there is starting to be more data on circulating tumor cells in the CSF, and better assays that can actually do a much better job of detecting cancer in the cerebral spinal fluid, because it doesn't just look for cytology. It actually can do some genomic profiling too, similar to what we're doing already in the bloodstream and the plasma. And to me, that's one of the really exciting things. Because as you know, with your HER2 alteration, if we can find something novel or something that we can utilize in the CSF, then that's wonderful. We always want to know every single option we have to make sure that we provide the very best care, the very best next step. So that's something that really excites me about the future.
Yeah, and I think I want to elaborate a little bit on the MRI stuff, because I think I've certainly been in the position where someone's having symptoms that could be consistent with leptomeningeal disease, and you get an MRI and the radiologist says, maybe, not clear. And it's tough, because I think we think of the MRI as kind of this donut of truth, where you go in there and it has the resolution and the ability to distinguish whatever pathology may be existing. If my shoulder hurts, get an MRI. It's just the truth donut. And the reality with leptomeningeal disease, rather than, I think, disease that goes to the brain itself or to other parts of the body, where you create this nice radiographically evident sphere of tumor cells, these kind of go on like a sheet. And they can be pretty thin. And it can be really hard for the MRI to tell for sure that there is cancer there, even though the symptoms are there. So I think that inability of the MRI to distinguish is where a lot of confusion comes into play. I mean, not only for patients, but for us too. Yeah. Like, how confident is the radiologist? And then the radiologist has to put their nickel down. And the consequences are really grave. If they're wrong and you've diagnosed someone with leptomeningeal disease, that can dramatically change treatment. Laura, could you speak a little bit to maybe your experience there, or that discrepancy where the MRI is inconclusive in diagnosing leptomeningeal disease?
Yeah, no, it's a really good point, Kyle, because it can be really challenging, especially because, not to get in the weeds too much, but there's different types of LMD too. Some are more localized and kind of nodular. Some are more kind of diffuse in nature, which means like kind of what you were saying with kind of the sheets of the membrane, which can be like very thin and more kind of spread out. And so it creates a challenge, because they're looking for these very small differences a lot. Some brightening of these membranes here and there, a little bit of nodules that's maybe new from the last brain MRI, And so one of the things, I do, it's always great to have a really good multidisciplinary team. And, we can, at Duke, we're really lucky because we have, the Brain and Spine Met Center. And so we have multidisciplinary boards, tumor boards once a week. And so we discuss any challenging imaging. And, we have a neuroradiologist. We have CNS focused, radiation oncologist. We have our neurosurgeons. And so it's always really important to, we get the image, we blow it up, really big on the screen, and everyone can get their opinion about, what do we see anything? What, as a consensus, what do we make of this? What would be the best next step? What would, whether that's a lumbar puncture, a repeat scan, very soon to assess how things are evolving. And that multidisciplinary approach, of course, with the patient in the center and ongoing discussions, to me, that's really been beneficial to make sure that we're doing the right thing. And the more heads in the game and the more knowledge is always a very welcome and good thing.
Yeah, and I like how you mentioned the neuroradiologist there, because there's a recurring theme on this podcast of where you go for certain things does matter. Yeah. Not every person who reads scans has the same level of comfort or diagnostic accuracy with identifying things within or out of their scope. Like if you're at a center where they don't see much leptomeningeal disease, it's going to be hard for them to make that call. So I think that's a real consideration for someone who is worried about it, is being seen at a center that has experience with leptomeningeal disease. Because, Laura, you were mentioning, this is pretty rare.
And to your point, Kyle, and this is something I like to bring up too, when treatment decisions get a little bit difficult, when there's nuanced, it is always, always good and right for either the patient to advocate for themselves and say, I'd really like a second opinion, or for the treating oncologist, because community physicians, community oncologists, they do a phenomenal job in treating so many different things. But I think in these more rare, in these difficult to treat occurrences, a second opinion at a major academic center that does have a lot of expertise in these things can be hugely beneficial. To just get that second opinion, discuss, if are there clinical trials, are there novel things that they can offer, some of which can be done at the academic center, other of which can be taken back and done at the more community site. But I think the power of a second opinion, everyone should always feel empowered to ask for one. Any physician anywhere at any institution, I think, normally welcomes them and says, absolutely, how can I help, get you there? But that's really important.
Yeah. And to your, we also have our brain and spine tumor board with people who trained at Duke. So it's funny, the connection of Colorado and Duke Brain and Spine Tumor Board.
Peter Fetchy.
Yeah. And it is interesting. In this tumor board, we see leptomeningeal disease probably almost every week. Maybe not quite every week, but pretty close. And that's the question, it's the whole group, is this leptomeningeal disease? If so, what do we do about it? And you talk to radiation oncology, you talk to medical oncology, and we're just trying to come up with a plan together. But it can be really hard to make those decisions independently, or if you're not used to seeing this all the time.
So I have my next question. So I've been reading it's more just knowing the community and then reading the data, and it's kind of conflicting to me in my brain, and I'd love to understand it a little bit more. So what I've been reading is, I think average time to get LMD is 18 months, or there's some kind of data out there that says 18 months. But then I also hear more and more people are getting LMD because they're living longer. And so I'm curious, because that 18th month mark, while it's great, it's not, 4, 5, 6 years. And so I'm curious, I guess, on the difference between those two, and why LMD behaves that way at the 18th month mark versus other people it's 5 years as an example, or just more about the behavior? Maybe we don't know.
No, it's a great question, Samantha. And I wish we knew even more than we did. I think, one thing with LMD is it's so variable because it's different tumor types, as well. And so, breast cancer behaves a little differently than lung cancer, and then, melanoma or some rare heme malignancies, even like leukemia sometimes. And so I think that there's so much variability that the statistics can be really confusing.
Okay. Yeah.
Because there's so many different factors, and even the subtypes of like breast cancer, HER2 positive versus estrogen positive. And then in lung, of course, so many of the actionable alterations that we assess for with genomic testing. And all of this, some of that can impact the risk of any type of CNS involvement, brain, spine, LMD. And then, of course, the treatments are variable within each of these subsets about how well they get into the whole CNS. So I think that's a great question, and it is confusing, and it is really variable because it's such a diverse type of involvement that can infect, so many types.
And I always thought LMD was the process when cancer felt like so pressured it had nowhere else to go, and so it kind of defaulted to this area because it just felt so much pressure. But there are some people that I know that were, before even starting treatment, had the diagnosis of LMD. And it's like, why? And this is a very simplistic question with probably a very complex answer, but like, I don't even know why cancer feels the need to go there when there might not necessarily be that much pressure on it at the time. It just seems weird to me.
No, I think it's a really good point. And I think cancer can behave really weird, right? Yeah. I mean, I think we've seen it so many times, and there's always like the joke that like, diseases don't read the textbook. And it's just, I agree with you though, is sometimes the presentations can just be, not the standard, I guess. And yeah, for whatever reason, sometimes these cancer cells seem like maybe they have more activity of breaking down those blood vessels more, and like that there's some knowledge with like VEGF can play a big role, and VEGF is the vascular and endothelial factor, and having more of certain things can predispose cancer to be like, oh, let's we're really good at breaking down blood vessels and breaking down these walls, so that's the place we're gonna go. And we know that the blood-brain barrier and other things are very like vascular, and if a cancer cell is really good at breaking down those walls and barriers, then like that's their getaway. And other ones, maybe they're not as good, so they're like, oh, it's not worth our time. Let's find our home somewhere else. It's very simplistic, but I think as we know more about, again, just like breaking down the tumor biology, we're seeing that even within like lung cancer or breast cancer, there's such a spectrum. And all of these genomic mutations, all of these tumor factors so influence the way that these cancer cells kind of think and behave.
Well, and it's interesting, what we're talking about a little bit is this concept of tropism, where a cancer cell has a proclivity to go to a specific area. And we'll even do this when we're looking at a new diagnosis of a cancer and we don't know what it is yet. You'll look and say, we get this in lung a lot because a lot of cancers spread to the lung, but they may not originate in the lung. This is actually true. We're speaking of the brain. It's true in the brain too. The most common diagnosis of a new brain lesion is a lesion from somewhere else. It's more likely to be from elsewhere. So the other things have this tendency to go to specific places. The lung, for example, you'll see that go to the adrenal gland. Like, that's weird. Why does it go there? I don't know. And so that proclivity to go to the brain or to the area surrounding the brain, these leptomeninges, I think we've been trying to figure out, is it a genomic thing? Is it part of the DNA? And again, the whole role of the DNA is to be a blueprint for protein. Like that's the construction plans for the cell that it is there. But ultimately, it's, what proteins is it expressing is going to determine what happens. And I don't think we do a great job yet of better understanding what's actually being expressed by it. We're just looking at blueprints a lot of the time, but it's a limitation of the technologies. I think the technologies are getting better to the point where we're better able to understand these things. The research is lacking a little bit, but that question, I think, is just $1 million question as to why do some cancers go here and why do some not? That I think a lot of people, Laura included, is working on figuring out the answer to that. But then also, you mentioned people living longer. And I want to highlight that a little bit too, because not every medicine gets in the brain, in the areas surrounding the brain, the same. Laura, maybe you could speak to that a little bit. I think of ALK as the predominant example, but there are many examples.
Yeah, no, I think, in breast cancer, a lot of the HER2 targets can achieve really good responses, like trastuzumab deruxtecan, the HER2 climb regimen with tucatinib. And I think breast has done probably even a better job than us sometimes of making some trials really focused on LMD. And so we have that data. We have some of those correlatives that are really nice. In lung, of course, to your point, Kyle, we have a lot of the fusions, ROS1, taletrectinib, most recently, lorlatinib with ALK positive, osimertinib with EGFR, with HER2, zongertinib, seems like it has really strong CNS activity. A lot of these have not been studied a lot in leptomeningeal disease. There's been some kind of phase 1-2 with higher dose Tagrisso or osimertinib, seeing if that could kind of have better CNS and LMD penetrance. There's been some studies of intrathecal pemetrexed, intrathecal amivantamab, I think was done at Memorial Sloan Kettering, which showed some pretty cool results.
And maybe explain intrathecal a little bit.
Yeah, good point. Sorry. Yeah. So intrathecal is when the therapy is injected directly into the CNS space. So sometimes that's done kind of like a lumbar puncture. Instead of taking out, you're kind of pushing in. Or sometimes there's something called an Ommaya, and that's actually when they put a small reservoir. It's a type of neurosurgery. They drill a little hole and put a little tube in there, kind of like an IV catheter into the brain, and then they patch everything up. And then there's a little bit of a bubble, a little bit of an opening, and they can kind of just inject the therapy directly in there. And the benefits of that is that can literally get exactly where the medicine needs to get to. And so that's some of the hope of some of these intrathecal directly into the CSF, directly, where these membranes are living, versus some of these, IV or oral therapies that really vary how well they penetrate into the CNS space.
Yeah, and I'll say nowadays, as therapies are coming out, I think because we've acknowledged this is such a need, there is a real strong intention behind making sure the therapy that you're making isn't just effective against the cancer you're trying to treat, but making sure it does cross into the brain quite well. So I would say even, and zongertinib is probably a good example, as you mentioned in HER2, that's the first HER2 tyrosine kinase inhibitor that was approved for lung cancer. But in other cancers, the first generations of stuff didn't get into the brain very well, almost always. And then we had to wait a decade or so for better therapies to be developed when we realized, we really do need to target the brain. But nowadays, I think as therapies are coming out, it's an intention from the get-go where from a how well does it work standpoint, if it doesn't get into the brain, it's not going to work as well as your competitors. From a pharmacy standpoint, if you want your drug to be on market for any appreciable amount of time, it has to achieve this minimal threshold of preventing CNS progression, brain progression, including the leptomeninges. So I want to offer maybe just a little bit of, we're talking a lot of intense stuff of, therapies not getting there, having to do Ommayas or injecting right into the spinal column there.
Yeah.
But I think the field is catching up, and I think things are looking maybe a little more optimistic than even 10 years ago, 5 years ago. Geez.
Absolutely. Yeah.
And I think my hope for the future is that when we're doing drug trials, not only is there a brain metastasis cohort, but there's an LMD cohort. And I think without that, we're going to be lacking in a lot of data that we actually need and crave, that I crave anyway. Because honestly, for HER2 specifically, even for brain metastasis, it's really hard to find data. And I know there aren't that many of us compared to other mutations, but the lack of data is concerning, and it would be really nice to get some level of, whether it be comfort or just more insight into whether this does work on LMD or not. And so let's create a cohort, whether that just be for 2 people, but it's a cohort. Let's look at it.
I agree. I couldn't agree more, Samantha. And I think, perhaps this is a role for some of the cooperative groups to have, trials focused on LMD and focusing on these agents, across academic community sites. Because even though relatively small in numbers, I mean, every patient is, of course, very meaningful, and we need that data, like you said. So I think, it's a call to action for all of us to try and do better and to make sure that these, underserved patient population that doesn't have a lot of data be included. And that would help us know how to manage things better, even dosing, because there's some data with a lot of the TKIs that if you increase the dose, maybe that can be effective, but it's such small studies that, sometimes we're going in a little bit blindly. I agree, though, that that's improving, and that's really encouraging. But I think there's always room for improvement.
Laura, could you speak a little bit to how patients with central nervous system disease are often excluded from trials? And this is true for leptomeningeal disease too, certainly.
Yeah. So it's true for almost any CNS with, brain metastases, spine metastases, LMD. Usually we've gotten a little bit better over the years that they now include asymptomatic brain mets. So usually not requiring any steroids, usually, not on any seizure medication, et cetera. And I think that's a small step forward. But I think, to your point, Samantha, I think we need a little bit greater of a step forward to say, if you have brain mets that are stable on steroids, if you have leptomeningeal disease that is, the patient is still able to go onto a clinical trial, has, able to do the things required for that they should be included, and then we need to broaden our criteria. And I actually, myself and a few of my colleagues at Duke in the brain and spine med program, we published a paper with a graded prognostic index, it's a GPA. And so what it does is it takes into account multiple factors, and it really highlights a lot of patients with any type of CNS disease can live, many months with all the newest therapies we have. And there's no reason for a lot of these patients not to be included. Because I think a lot of times pharma worries, well, we don't want our drug to, look bad or things like that, which are, I get that that's their concern, but I think we're trying to show them more and more that having a cohort is really important and won't be detrimental to them, but could actually be really, as you mentioned, Kyle, could help distinguish that drug, and not to mention help people who really need help.
Yeah, I find it such an interesting dilemma that we're navigating in real time as a community, where historically individuals who had a lot of disease in the brain, we didn't have good things that targeted it. So I think at the time they said, well, let's not include those patients in the trial because we don't really expect much to work there anyway. And those patients do so poorly that if a couple more are in the treatment arm than in the control arm, you may lower your effect artificially because you have people that tend to do worse.
Yeah.
The flip side of that now is a lot of these therapies are coming out and they work in these areas and they're still being excluded from trials. But I'm like, if you show me that works there even a little bit, like that's what I'm going to reach for. So I think the irony has kind of come full circle here, where we're really craving that data as providers.
Yeah.
But even I think from a moral, ethical standpoint, if someone can be on the trial and it's likely to help them, then we should be enrolling them.
Can we talk about proton therapy, please?
All you, Laura.
So I was at the longevity conference last year, and there was a CNS presentation, and it went into depth into proton therapy. And there was a lady, I apologize, I've forgotten her name, but she was talking about having had proton therapy and how she was still alive years later. And quite a few people in the room kind of perked up like, oh, wow. I know that proton therapy is only available in very few locations right now. So accessibility can be a barrier, but I would love if you could please talk about proton therapy, how that might be different to other types of brain radiation, and the hope that there might be there for the future.
Yeah, it's a great question. I think a lot of us, based on some of the early data, are really excited about protein therapy. And I think already, in some international sites, I think they're even maybe a tiny bit even ahead of us. And I'm looking forward to hopefully that they'll publish more and more about their findings. And I think, as to your point, it's not available very widely in the United States yet. I was so happy that Duke has gotten funding to build one.
Amazing.
So stay tuned in, I guess, like 2 years maybe or so, but hopefully as soon as possible. But, radiation is always one of the backbones of treatment for any type of CNS involvement, including leptomeningeal disease. And, depending on where the disease is, if it's very focused, we could talk about stereotactic radiosurgery, which is a type of very focused radiation. Gamma knife is also one of the more focused ones versus, of course, whole brain or even craniospinal radiation, where, if, as we talked about, LMD can be anywhere across that CNS. And historically, it's been helpful. There are side effects, unfortunately, with radiation. But I think what I think excites a lot of people with proton therapy is it can have a little bit less side effects and even like more efficacious. So it can work even a little bit better. And I'm not a radiation oncology expert by any means. But from what I've heard and from what I've read, I'm really excited for it. Kyle, I don't know if you can.
I don't have much to add there. I'll say a plug for an episode we have coming up with one of our radiation oncologists, because this stuff is really complicated.
Yeah.
And I would agree that the gist is you can get smaller margins, which means less radiating healthy tissue. So you can push it a little harder, and particularly in the brain. And I mean, this is true in not just leptomeningeal disease, but other areas in the brain where you obviously don't want to be radiating healthy brain tissue, and this may let you achieve better control, sparing that. But again, proton centers are insanely expensive. It's a whole new machine, so it's not like you can renovate a previous machine to become a proton machine.
Yeah.
I think you need a whole new thing. And often that's building infrastructure. Like you have to build the building that it's going to be in. So yeah, I think we also have an initiative here, if I remember correctly. But again, like that, these are the limitations. Like where are we going to put it? So it's tough. But a lot of people, I think, have to travel if they're going to get that. And then you get into the common question where, is the juice worth the squeeze? Is the benefit from proton over conventional radiotherapy enough that it's worth traveling to one of these big centers that may be not near you? Hard questions to answer. But maybe another reason to pitch the tumor board kind of stuff,
So when someone is newly diagnosed with LMD, and we kind of touched on this a little bit, but who do you think should be on their team that is different from maybe their current team in terms of expertise? I know we briefly touched on a brain radiology specialist and things like that, but I'd love to hear your thoughts so that people can kind of gather their thoughts on who I might need to be in my group.
No, I think it's a great question because I think having a good team and good support for the patient, for their family, for their caregivers is very important. And so, obviously the medical oncologist, but having a radiation oncologist on board, sometimes a neurosurgeon can be helpful, especially we mentioned the Ommaya a little bit. They would be the ones to place that. Sometimes they can also talk about, one thing we haven't talked about a whole bunch is because of those membranes and that fluid, sometimes there can be pressure when some of that fluid builds up. And so sometimes there's something called like a shunt to kind of help redistribute some of that fluid. And if needed, the neurosurgeons are really important there. One of the things I always like to a team to be involved pretty early on is palliative care. I think sometimes there's a misconception. Palliative care is like a huge tree, many, many branches. And, the majority of those branches, they really just focus on symptoms, helping with nausea, helping with pain, helping with feeling tired, fatigue. And then one branch, of course, is hospice, which is end of life. But when people say palliative care, for the most part, we're talking about just the symptom and the quality of life support. And it's, hospice is its own branch. So I never want people to get afraid when I mention palliative care. It's such an amazing tool that can really offer great support. And then, of course, social workers, physical therapy sometimes to help regain that strength, nutritionists, really having that support across the board.
Well, I think we're, in the discussion of symptom management and palliative care, we're kind of dancing a little bit around prognosis. And I understand that for every disease, the prognosis is a function of the overall how well that disease type does. Melanoma tends to do differently than lung, tends to do differently than breast. Subtypes tend to do differently. But generally speaking, once someone gets LMD, how does that change their prognosis compared to if they didn't have LMD with the same thing?
It's a tough conversation. I always say with LMD, I'm worried, right? This worries me because it does have an impact on the prognosis. And it's something that, again, is really helpful to have a discussion with the multidisciplinary team because we always want to know what treatment options are available. How well do we think these treatment options will work? What's going to be the impact on quality of life? And something you mentioned before, Kyle, it's a phrase that we use is, the juice worth the squeeze. We always want to be weighing how much good can our therapies across the board, whether it's IV, oral, radiation, et cetera, surgery, how much good are they going to provide? And what's the risk of harm? And right now, that prognosis, as you alluded to, varies a lot. And it's really scary to say that in some cases, depending on the severity, sometimes it can be days or weeks. Whereas other cases, it can be months and months and months. And so I think it's just, again, it's always putting that specific patient in front of you in the center and basing all of the conversations around that unique individual. And there's a lot of hope, and there's a lot of upcoming treatments and novel treatments that I hope will extend that more and more. But it's a tough conversation to have.
Yeah, and I appreciate there's different levels of involvement. How much are you seeing there? Is it diffuse? Is it really focal? But yeah, I think my approach is pretty similar. There's a patient who I was caring for in the hospital not too long ago who was bedbound by the leptomeningeal disease. Many nerves are not working, can't walk. And the challenge is we can deploy these therapies that I think may work. But in other instances, for example, let's say you have a primary breast cancer. If your treatment doesn't work, you have some room for failure. You have some room for the tumor to grow and it not cause a devastating effect. The thing that I think scares us all about LMD is the time interval to make the best decision is relatively short.
Yeah.
And that's kind of why getting through, or at least discussing any new symptoms you may be having that may be consistent with leptomeningeal disease, or you're worried about it, something new. These are things to not sit on because people, the care teams can't wait that long. And I'm sure as a patient, it can be really, really hard when so many things could potentially seem like that. As you were saying earlier, Samantha and Laura, how often do we have headaches? Like, headaches happen all the time. Yeah. But, and this one seems worse than typical. Am I calling the helpline? So those are things that are just impossible decisions to navigate. And Samantha, as you were saying earlier, you don't want to be just causing fear and chaos, but you want people to be informed and appropriately address concerns.
Yeah, absolutely.
Hard to navigate.
Yeah, I almost feel bad when I'm educating people sometimes about it, because I'm like, oh, I've added in a new additional stress for someone. But like you said, it's so important to be aware. I feel like it's important to catch it as early as you possibly can. And so I just think education is key. I honestly wish it was talked more about in advocacy groups. And that's why I was happy to see it in the longevity conference last year, that it was kind of talked about head on. It probably made a lot of people very uncomfortable, but it's just something that needs to be talked about. And honestly, the term CNS, I think, is also very confusing to people. As an example, I was intending to go into this CNS lecture from longevity thinking it was brain metastasis and LMD, and then they start talking about spine metastasis, and I'm like, wait a minute, that's me. And then I started to freak out. I'm like, I have CNS? Like, what? I don't think there's enough education about people that just have spine metastasis that actually is CNS. I don't know what the appropriate term is, but it's got into the CNS system, so to speak. I don't know if that's the right term, but
and more confusing, if it's in the spine bones, it may not be in the CNS.
Okay, so now I'm even more confused because okay, so that's an important clarification, because when people talk about spine, I think they automatically think about the bone.
I had this exact confusion in clinic last week. Someone had a spine instability, like their bone was unstable. Separately from that, they had a metastasis in the spinal cord, meaning the central nervous system nerves.
Okay.
And what the surgeon wanted to do was very ambiguous to us. Did they want to operate on the cancer in the spinal cord, or did they want to operate on the spinal bones? So we had to navigate that confusion. you're not the only one to be
Okay.
confused by that.
Well, I'm glad we had this discussion then, because literally when I see CNS in trials, I'm like, oh, I don't qualify. So that's not true. So that's a very important clarification, I think, and maybe some improved education and awareness there of when we're talking about the spine, specifically what part of the spine are we talking about?
That's a really good point. But like the spinal cord, as Kyle mentioned, is different than just the vertebrae, right? Just a bone that makes up the spine. And that's a really good point. Yeah.
Yeah, we have someone here who's working on understanding spine metastases. So we'll have to get him on for a future episode, because we're trying to, his whole role as a spine surgeon is, you stabilize the spine. We're not usually scooping cancer out surgically, but the spine is pretty important to be a stable column. It has neurologic complications if it's not. But also, why does cancer go there sometimes and other times not? This tropism we're talking about, why does it go to the leptomeninges? Why does many times it gets to the spine, it doesn't go into the spinal column? That itself is kind of weird. So, no, and better understanding that. And, us, we're working on therapies, particularly cellular therapies like CAR T cells and things like that you can inject into that area. Or you can give through the IV and hopefully it has some treatment effect there. But the field is working on this. It's just, I don't have to tell either of you how slow the pace of research is. But it's not, but at least now I think it's more in the greater community's eye as an unmet need. And probably that's a function of us doing better overall, that we now have, I dare say, the privilege, as you were saying, of individuals living long enough to get this more. But, it does offer us the lens to prioritize it.
I greatly appreciate you coming on to cover this topic. Like I said, more awareness needs to be done. So I really do appreciate it. You answered every single one of my questions. So thank you. Thank you for allowing me to relay everything from my brain to be more informed. And I really hope this helps some other people out there too.
Yeah, no, thank you, Samantha. And thank you for sharing your own experiences and, the very thoughtful way that you not only think about you and what you're going through, but also how you think of others and what they may be feeling and what they may be fearing. So I really appreciate you sharing all that and being a great representative.
Thank you. That means a lot.
And Laura, if you could leave our listeners maybe with one takeaway about leptomeningeal disease as a whole, what might that be?
I think it's scary. I think it's important to know your body, to communicate with your doctors. But there's a lot of hope. There's a lot of hope with how we diagnose, with circulating tumor cells, with circulating DNA from the CSF, from that fluid. There's a lot of hope, as we were talking about, with better targeted therapies, that can go directly where it needs to go into that fluid. Kyle, you mentioned like CAR T therapies that are designed to literally have your own immune system really much better and more intelligently target the cancers. Lots of new developments. I think we are moving much more towards being inclusionary of more patients that really need better therapies. I'm hopeful that will continue to improve. So I think the future, while scary, it's bright. And I think our lung and all the other communities will continue to really work together to try and improve outcomes and improve quality of life over the next few years.
Laura, thank you so much for joining. Awesome to get your expertise here. And Samantha, thanks for asking very enlightened questions and sharing your experience. All right, everyone. If you have any other questions, you can go to crackingcancer.org and fill in the things you'd like to hear about. But stay tuned for next episode. Bye, everyone. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.